Dr. Shivakumar has authored 31 international and 12 national publications and is known for innovations like using virtual reality to train CPR in the community. Sepsis remains a challenge. It's time to update our arsenal for 2025. We welcome you, sir.
Good afternoon. Welcome, Dr. Shivakumar. Shivakumar was my colleague in KVG Medical College. We worked together for 3 years.
Good afternoon, everyone. Thank you, chairpersons. And at the outset, I would like to thank organizing committee of ISACON 2025 by giving a opportunity to present a topic in ISACON Karnataka 2025. So the topic given to me is Surviving Sepsis Kit 2025. Unfortunately, 25 is not released yet. So it's supposed to be released by 2025. So I'll be presenting a reset guidelines of Surviving Sepsis Guidelines 2021. So this is the reset guidelines, Surviving Sepsis Guidelines, international guidelines which by a Society of Critical Care Medicine, European Society of Intensive Care Medicine and International Sepsis Forum. These collaborated, they formed the Surviving Sepsis Guidelines. So brief history, it's all started in Barcelona in 2002. The International Forum on Sepsis, Society of Critical Care Medicine and European Society of Critical Care, Intensive Care Medicine, they formed the collaborations to start a Surviving Sepsis Guidelines. The declaration was done in Barcelona. Later on, in 2004, the Sepsis Guidelines, first Sepsis Guidelines were formed. Later on, every 4 years, 2008, 2012, 2016, and recently in 2021, the guidelines was released. I will be discussing on 2021 guidelines. So in between, there are a few bundles were also came. The first bundle was 2004, the 6 hour, 12 hour bundle. Later in 2013, 1 hour, 6 hour bundle. There was a lot of criticism regarding these bundles. 1 hour and 3 hour, 6 hour bundles, there was a criticism. Later in 2018, the 1 hour bundle has came. Now we are following 1 hour bundle of sepsis, survey sepsis camp. So before further going, we have to understand the implications and the type of statement. So without understanding, we can't move on further. There are the star mark is best practice guidelines. Means there is no point in your self-judgment. You have to practice as per the guidelines or recommendation given by the guidelines. So then a strong graded guidelines is a 2 exclamatory mark is there, then it is a strong. If it is a green color, it is for. Remember, it's a red color, it's against. If it is a 1 is there, weak recommendation is again green is for and red is against. This is a weak recommendations. So remember, strong guidelines, recommendation has to be followed. There is a little clinical decisions. You should not take a self-decision regarding these guidelines, strong recommendations. Regarding weak recommendations, these are not tailor-made. This, you have to put your clinical judgment before deciding what is the best treatment or interventions is required for this particular patient. So what are the different about 2021 guidelines? The greater emphasis was on the panel diversity regarding gender, geographic distribution, economic distribution. They have divided as per WHO classification. They consider all the economic, even low, middle economic countries. Before they was confined to the Western countries. Now it was a larger geographical area study was done. The questions selected following international evaluation practice and uncertainties. The PICO question is about a long-term outcome after a sepsis were added. PICO means patient, intervention, comparison and outcome. And users have an evidence decision framework as a transparent and structured system for formulating a recommendation. These were the newer things. There are a total of 93 recommendations. There are few newer recommendations like capillary refill time was added, to assess the tissue perfusion. Empirical MRSA was not there in before. They were just stressing on the antibiotic therapy. Empirical MRSA guidelines were added. Then empirical fungal coverage were added. Peripheral vasopressor, starting a peripheral vasopressors started. Before they recommended only to use on the central venous catheters. Now they added peripheral vasopressor use. There are a recommendation about levosimendan, HFNC or NIV. Use of ECMO was also discussed in these recommendations. And post-ICU follow-up was the new recommendation they are added in 2021 guidelines. Before moving further, the sepsis 3 definition, which was derived from a third international forum on sepsis, the sepsis should be defined as a life-threatening organ dysfunction caused by dysregulated host immunity because of infection. So, this is a life-threatening organ dysfunction caused by dysregulated host immunity secondary to infection. Then we should understand what is organ dysfunction. The organ dysfunction is if SOFA score, sequential organ failure assessment score, is increased more than 2. It is called as organ dysfunction. This is about sepsis. What is septic shock? Septic shock is when a patient has clinically identifiable infection along with patient requiring a vasopressor to maintain a mean blood pressure more than or equal to 65 or with a lactate level more than 2. Then it is called as septic shock. One is requirement of vasopressor to maintain a mean blood pressure of more than 65 plus lactate more than 2 is considered as septic shock. Initially there was sepsis, severe sepsis and septic shock. Now they are confined to sepsis and septic shock only. So coming to screening, first regarding screening for a patients with a sepsis and septic shock, for a hospitals and a healthcare system, we recommend using a performance improvement program. It was also there in previous recommendation, 2016 recommendation, which includes sepsis screening for acutely ill patients by using a standard operating procedures. The screening and standards for a screening, strong recommendation, the moderate level of evidence. Regarding SOPs, which was not there in the previous recommendation, they have added SOPs for each institutions. It is a strong recommendation with a very low level of evidence. So what to use for a screening? So initially, the strong recommendation was there for QSOFA for a screening. Now it is a strong recommendation against using a QSOFA. Remember. So now they don't use a QSOFA. Quick SOFA is not useful in screening a patient of sepsis or septic shock. Rather use either a SIRS, other national early warning score system or modified early warning score systems. Don't use QSOFA for screening a septic shock patients. So for adults with suspected having a sepsis, suggest measuring a blood pressure whenever feasible. When your center has point of care lactate measurement is recommended because it is also a part of sepsis shock definition. So why QSOFA is recommended? It is only 3 parameters. One is respiratory more than 22, altermentation less than systolic blood pressure less than 100. These 3 parameters can happen with many other conditions. So they removed QSOFA from screening a septic shock. So coming to a lactate is a part of 1 hour bundle or also a part of sepsis 3 definition. Lactate cutoffs determined by elevated by 1.6 to 2.5. Sensitivity ranges from 65 to 83%. Specificity ranges from 80 to 85%. Studies show that there is association between use of point of care lactate measurement and reduce mortality. However, there is an inconsistent reason. So only based on the lactate you can't go ahead. So there are inconsistency. You have to think about whether the patient has a liver failure, whether the patient is taking drugs like metformin, either is hypovolemia is due to gastroenteritis. So you consider all those things. These things may raise a lactate level may not have a sepsis or septic shock. Okay. So other most important is limited availability in a certain resource limiting set. This is the disadvantage. So they have added something else, that is a CRT, that capillary refill time is added in a limited resource settings. So coming to initial resuscitation, so best practice guidelines is sepsis and septic shock is a medical emergency. You should recommend that treatment and resuscitation should begin immediately. So there is no second thought, this has to be followed. So coming to for the patient with a sepsis induced hypoperfusion or septic shock, suggest that least 30 ml of crystalloid balanced salt solution should be used within 3 hours. So this is a weak recommendation with a low level of evidence. Initially, the recommendation was initial resuscitation with a crystalloid solutions within 3 hours. They have recommended, now it is suggested. By why they are suggested? There is various studies say you have to give the fluid based on the dynamic monitors rather than a fixed dose. There is EGDT was there initially, there are process trial was there, then in promise trial, the arise trial, these are triology of sepsis we may be knowing. So they suggested there is no difference between usual treatment with the EGDT. So EGDT increases vasopressor users and increases hypervolemia. That's why their recommendation downgraded from a strong recommendation to a weak recommendation regarding 30 ml for fluid. Got it? Okay. So initial recommendation for adult sepsis or septic shock, we suggest using a dynamic monitors for fluid management. Use a dynamic hemodynamic monitors. Use SVVs or a pulse pressure variations, so stroke volume variation or cardiac output if the feasible, use it. So that is suggested rather than using CEP, heart rate or blood pressure or urine output. Don't use all these things, use dynamic measures. This is a weak recommendation, very low level of evidence. So coming to an adult with a sepsis or septic shock, suggest guiding a resuscitation to decrease the serum lactate. This has been, so use your target to decrease the level of serum lactate, is still present. Okay. For sepsis with a septic shock, suggest use a capillary refill time. There are studies, so suggest comparing a lactate, especially the Andromeda shock study is there with comparing a lactate with a CRT. There is no mortality benefit, or there is no difference in the stay of hospital stay or the mortality with respect to whether you use CRT or lactate. But still, lactate is better whenever feasible. Otherwise, in a less resource settings, use a capillary refill test. This is a new recommendation. Coming to a fluid resuscitation, there is no prospective interventional studies comprising what different volumes should be used. There are various studies regarding what volume has to be done. So there is a potential harm associated with the fluid overload, particularly prolonged ventilation, AKI, these are increased, especially when you use normal saline. So dynamic measures are demonstrated to be a better diagnostic accuracy at predicting a fluid responsiveness. Dynamic measures includes passive leg raising, SVVs, cardiac output monitor, VTI, you can use it. There are so many dynamic compared to the static measures. Coming to mean arterial pressure, for adults with a septic shock, recommended initial target of mean arterial pressure should be 65. It should not be very high. It should be at least 65 or equal to 65. Don't maintain high level of mean arterial pressure. There are various why this 65 has come. There is a 2014 sepsis PAMS trial. They have recommended based on the RCT in the septic base, comparing a target of 65 to 70 and 80 to 85. They compared. There is no mortality benefit if you maintain higher blood pressure. Only thing is it causes increased requirement of vasopressors, which increases atrial fibrillation. That was, and arrhythmias. The advantage in a chronic hypertensive patients, if you maintain higher, in a subset analysis, they find that maintaining higher blood pressure, the requirement of RRT comes down in a patients with a higher blood pressure, especially in a chronic hypertensive patients. The another 65 trial was done in 2018. As per recent RT, in the age group above 65, they conducted restrictive blood map of 60 to 65 and map of higher map. They found that there is no significant difference in the mortality or other side effects. So finally they come between these things, that 60 to 65 and 65 to 70, these two trials, they came to 65 is the ideal blood pressure which you can maintain in a septic shock patient. So targeting higher blood pressure requires a higher vasopressor, which leads to increased arrhythmias, especially atrial fibrillation. So don't use higher targets in a septic shock patients. Given the lack of advantages associated with higher MAP targets, lack of harm to a patient if you maintain a 65 mean arterial pressure, so they recommended 65 is an ideal initial target in a patient with a septic shock patient. Coming to ICU admission, this is the newer recommendation. When the patient comes to an emergency department, as soon as possible, resuscitate and send it to the ICU. Within 6 hours, they recommend, this is a weak recommendation, low level of evidence, they recommend that patients should be shifted within 6 hours of coming to the emergency department, because you have a better facility, dynamic monitors will be there, fluid management can be based on the dynamic monitors. So they recommended early shift to the ICU. Delayed ICU admission is associated with increased mortality, duration of ventilator days, and longer ICU stays. So better shift a patient from ER to ICU within 6 hours. Coming to infection, for adults with a suspected sepsis or a septic shock, unconfirmed infection, we recommend continuously re-evaluate whether it is an infection or some other cause is causing a shock. If you find that patient is an infection, you start antibiotic. Otherwise, you have to continuously evaluate. In the patient with septic shock, if you are not confirmed with infection, you should start antibiotic within 1 hour. If the patient does not have a shock, you can delay up to 3 hours while continuously re-evaluating. For adults with a possible septic shock, high likelihood of sepsis, we recommend administering antibiotic within 1 hour in a septic shock, but in a sepsis without shock, if he has a possible, you can administer antibiotic, but continuously re-evaluate. But in previous guidelines, what was suggested was, in all the patients, whether it's a septic shock or a sepsis, administer antibiotic within 1 hour. That was the previous recommendation. Coming to, for adults, a possible sepsis without a shock, we recommend rapid assessment of likelihood of infection versus non-infectious causes. So, for adults with a possible sepsis without a shock, we suggest a time-limited course of rapid investigation, and if you concern there is an infection is present, you administer as soon as possible, or you can evaluate till 3 hours. Within 3 hours, you administer the antibiotic in case of sepsis without a shock. In a septic with shock, you have to administer within 1 hour. So, antibiotic timing, with this shock is present, administer in all the patient within 1 hour. If the shock is sustained, if the sepsis is probable, administer antimicrobial immediately, ideally within 1 hour. If you are suspecting infection with the shock, if you are not suspecting infection and no shock is present, you can wait till 3 hours. If you are suspecting infection, you administer even without a shock within 1 hour. Okay. Timing of appropriate microbial culture, best practice time, we recommend the appropriate microbial culture before starting antimicrobial. Ideally, it has to be sent. Appropriate, whether it is a blood or a sputum or a urine culture, has to be sent within 45 minutes. Later, you start antibiotics, if possible. So, it is not a mandatory, but they recommend that it has to be done. If you are possible to do a sputum culture, urine culture, it has to be done. Otherwise, if the septic shock is there, you can't able to draw the culture, you can give antibiotic. So what about the biomarkers? We used to use the biomarkers for diagnosing procalcitonin for diagnosing the septic shock. Now, for adults with the suspected sepsis or septic shock, we suggest against using a procalcitonin to diagnose a septic shock or sepsis. Don't use a procalcitonin for diagnosing a sepsis or septic shock. A meta-analysis of 30 studies, the procalcitonin has pooled sensitivity of 77% and a specificity of 79%. In a critical ill patient, meta-analysis in the 3 trials found no difference in short-term or long-term or ICU stays or mortality. Whether you use the procalcitonins to diagnose or not to diagnose, don't use a procalcitonin to diagnose a sepsis. It can be used for de-escalation. I will be discussing about that. Okay, coming to antimicrobial. So, adult patient with a sepsis or septic shock, high risk of MRSA, recommend using a empirical antibiotic which covers a methicillin resistant staph aureus. You have to cover the methicillin resistant malaria. If you are suspecting a MRSA, this patient is particularly prone for MRSA. This recommendation was not there before. And in a patient who are MSSA, methicillin sensitive staph aureus, then don't use a drug which covers a MRSA. This increases the mortality. So if MRSA is present, definitely use. If MSSA is if you are suspecting a patient is having MSSA, don't use drugs which covers MRSA, which increases the mortality. So those which are the patient which increases MRSA, so patient with the previous MRSA infection or colonization, or recent IV antibiotics, history of recurrent skin infections or chronic wounds, or presence of invasive devices, hemodialysis patients, or patient hospital admission and severity of illness. If Apache scores are very high, definitely you have to consider that gram-positive MRSA coverage should be given. So coming to MDR organisms, for adults with a sepsis or septic shock, high risk of multi-drug resistant organisms, gram-negative GNBs, if there, we suggest using a 2 antimicrobials, gram-negative covering a gram-negative coverage. So only if you are suspecting MDRs. For adults with a sepsis septic shock with a multi-drug resistant organism, we suggest against using gram-negative agents for a empirical treatment as compared to 1. So if you are not suspecting MDR, don't use 2. If you are suspecting MDR, definitely use a 2 antibiotic which covering the gram-negative agents. For adults with a sepsis or septica, we suggest against using a gram-negative coverage when the culture and susceptibility results have come. You have to de-escalate to 1 appropriate antibiotic. Except there are few exceptions like NDM, Acinetobacter, where you have to give a 2 or 3 antibiotic. Apart from few exemptions, you have to continue with susceptible antibiotics. So what are the risk factors for MDRs? We know that the proven infection or colonization of antibiotic resistant to antibiotic resistant organism with the preceding year, local prevalence of a resistant organisms, hospital acquired pneumonia, these are more MDRs compared to the community acquired, broad spectrum antibiotic use within preceding 90 days, and concurrent use of a selective digestive decontamination, travel highly to the endemic areas, hospitalization abroad. This is especially important when the Western people are coming to India and get hospitalized. So those are things. Then other thing is antifungal. There is for adults with a sepsis or septic shock, if you are suspecting a fungal infection, definitely use. Where you will suspect a fungal infections, solid organ transplant, neutropenia, colonization, candida colonization is present. So these Apache scores are high. If your patient is admitted with a longer duration, with persistent procalcitonin is high, in those patients you suspect a fungal infection, you start empirically. If you are not suspecting a fungal infection, definitely don't use antifungal agents empirically. If you are suspecting or beta-D-glucan is present, so in those patients you have to use the antifungal agents. You have to take the clinical considerations, evaluate with if the fungal, you are suspecting a fungal infection, you have to use antifungal agents. So what about the antimicrobial delivery? So initially, there is no recommendation regarding antimicrobial. Now they suggest that whenever you use the beta-lactam agents, you have to give infusions, especially in the septic or septic shock patients. Meropenums, carbapenems, beta-lactams, cephalosporins. Always give by infusions. This recommendation gives a beta-lactams only, carbapenems and cephalosporins and beta-lactams will infusions, other drugs. They because time dependent and concentrated dependent varies. So time dependent drugs has to be given infusion, concentration dependent intermittent boluses. So for adults with a sepsis or septic shock, we recommend optimizing a dosing strategy based on the PKPD models. What I am telling is they be depending on the PKPD, whether it's a time dependent or concentration dependent, based on that you have to administer the drug. Source control is very important for a patient with a sepsis or septic shock. Identify the source, whether the patient has a perforation, patient may be having a perineal abscess, may have a hydronephrosis, pyelonephrosis may be there, emphysematous pyelonephrosis, may ignore this. So you identify the source, and source elimination is very important. These are the best practice guidelines. So you don't go on giving antibiotic, just identify the source. For adults with a sepsis or septic shock, recommend a prompt removal of certain intravascular devices. Suppose you have a central line for long durations, hemodialysis catheter, arterial lines. If you are suspecting a vascular access device infection or CLAPC, you definitely have to remove those devices. Okay. Coming to a de-escalation of antibiotic, for adults with the sepsis or septic shock, we suggest daily assessment of de-escalation. Clinically, you assess daily, then you assess that whether the antibiotic can be stopped or de-escalated to a lower antibiotics. So this is a weak recommendation, very low level of evidence. For adults with the initial diagnosis of sepsis or septic shock and adequate source control, we suggest shorter duration of antibiotic. There is no, most of the studies suggest that there is no difference in the mortality with respect to a shorter duration or a longer duration of antibiotic. The only thing which increases is a MDR resistant microorganism if you use a longer time. So 5 days is the what recommended, sometimes 7 days in some infections. Very few infections you require weeks together. So for adults with the initial diagnosis of sepsis or septic shock, adequate source control where optimal duration of therapy is unclear, we suggest a procalcitonin along with a clinical evaluation. Here the procalcitonin. Diagnosis of sepsis, you don't use a procalcitonin. For de-escalation, use a procalcitonin. Coming to fluid management, we all know that for adults with a sepsis septic shock, we recommend using crystalloid balanced solution as a first line solution. So for adults with a sepsis or septic shock, we suggest using a balanced crystallized instead of normal saline. This was a new recommendation. Initially in 2016, it suggested either balanced salt solution or a normal saline. We know that normal saline is associated with the hyperchloremic metabolic acidosis. There is a vasoconstriction of renal vessels. It increases AKI, so they suggested balanced salt solution is better. For adults with sepsis or septic shock, we suggest using albumin patients when required. This, when you are giving a large amount of crystallized, you can use a 4% albumin. As per a SAFE's trial, even Albinos trial, they both recommend albumin except in case of traumatic brain injury. Don't use a albumin in a traumatic brain injury. 4% can be used when a large amount of crystallized is required. There is no difference in mortality benefits or long duration of ICU stay. For adults with a sepsis or septic shock, we recommend against using a starch. They also against using the gelatin. These are not recommended in a septic shock. Coming to vasoactive agents, this is a strong recommendation. For adults with a septic shock, we recommend using norepinephrine as a first line of agent in a septic shock. We all know that norepinephrine is the first line. So other, we know that dopamine is a strong recommendation, high level of evidence. Vasopressin is a moderate level of evidence. These are all strong recommendation. Epinephrine is low, so then angiotensin 2, very low. So for adults with a septic shock, norepinephrine with inadequate mean arterial pressure, we suggest adding vasopressin. So when you start with the norepinephrine, so then if still the blood pressure is less, the mean blood pressure is less than 65, you add, next is vasopressin. Don't add some other drugs. So you add, what is the dose where you can add a norepinephrine? When you exceed a 0.25 to 0.5 microgram per kg per hour of norepinephrine, then you should start vasopressin. Don't delay it. For adults with a septic shock, noradrenaline with the inadequate mean arterial pressure, we suggest adding vasopressin instead of escalating the dose of noradrenaline. Okay. For adults with a septic shock, inadequate mean pressure levels despite norepinephrine and vasopressin, we suggest adding epinephrine. For adults with a septic shock, suggest against using terlipressin. We usually use in a patient's splanchnic vasodilation in case of CLD patient, otherwise don't use terlipressin. For adults with a septic shock with a cardiac dysfunction, you can add dobutamine or epinephrine. So this can be added. For adults with a sepsis or septic shock with a cardiac dysfunction with a persistent hyperperfusion, adequate volume status and arterial blood pressure, we suggest against levosimendan. Levosimendan is not added, only it was recommended in peripartum cardiomyopathy. This is a calcium receptor, calcium sensitizer, so we don't recommend levosimendan over dobutamine. So coming to for adults with a septic shock, we suggest invasive monitoring blood pressure over the non-invasive. Wherever feasible, monitor invasively. Septic shock patients is recommended. The weak recommendation for adults with a septic shock, we suggest starting vasopressor peripheral. This is the new recommendation. Wherever it's suppose low resource settings, whenever it's not possible to get a central venous line, so you can start peripherally also. But make sure it should be up to 0.25 microgram per kg per hour. Not more than that of noradrenaline dose. So if it requires more than that, you have to start central line. Okay. So there is insufficient evidence to make a recommendation use of restrictive versus liberal fluid. So there are so many trials have come restrictive or liberal fluids, sir. Ultimately, you have to, after 24 hours, you have to monitor dynamic hemodynamic parameters, then you give fluids. There is no recommendation whether to give a restrictive or liberal fluids. So coming to vasoactives, this summary, now you start with the first is noradrenaline or norepinephrine. For a patient with a septic shock, for first line is a norepinephrine. If the target of MAP is 65, okay. Consider arterial blood pressure monitoring. If central venous access is not possible, consider initiating peripherally. If MAP is inadequate despite a moderate amount of norepinephrine, consider vasopressin. If this cardiac dysfunction is there, you can add dobutamine. Also, you can consider epinephrine. So coming to ventilation, most of these guidelines are similar to the ARDS guidelines, like 6 ml per kg tidal volume, then peak pressure is platelet pressure is not more than 30, the high PEEP versus low PEEP. These are the recommendations. So there is no, most of these recommendations as per the ARDS net protocols. I will not be going in detail about this. Only selective things I am getting. Then regarding a prone ventilation, in sepsis patient, you can do a prone ventilation at least 12 hours prone ventilation. If requires, oxygen saturation is not maintaining, even after all these things, all the strategies, so you have to do a prone and maintain with more than 12 hours of prone ventilation. So if you want to use a neuromuscular blocking agents, use intermittently, don't use continuously. That was another recommendation. Use the intermittent doses. Then in a patients with ARDS, for adults with sepsis with severe ARDS, suggest using a veno-venous ECMO when conventional mechanical ventilation fails. Initially, so when the septic patients were there, it was not recommended. When there is a patient is infection, the ECMO was not recommended. Now they recommend that use a VV ECMO. In VA ECMO patient, if you have with a severe septic shock not responding to vasopressin. Coming to oxygen target, what is the target we use? Normally we use a target of 88 to 92 is the target. What ARDS net says, same target. If you coming to a PaO2, 55 to 72. PaO2 if you take 55 to 70, or else if you use SpO2, 88 to 92. So ICU ROCKS trial, the conservative therapy did not significantly affect the primary outcome, which was number of ventilator-free days compared to the liberal oxygen therapy to a conservative oxygen therapy. So mortality at 90 days and 180 days remains same. So conservative oxygen therapy is better. What are the additional therapies? Coming to steroids, for adults with a septic shock, an ongoing requirement of vasopressor, we suggest using a IV corticosteroids. It was against in the last 2016 statement. Now, when the patient is high dose of vasopressor is there, then you should use hydrocortisone, which has a mineralocorticoid activity. Don't use Dexona in these patients. Use a hydrocortisone. When to use? When the dose of norepinephrine or epinephrine is more than 0.25 microgram per kg per minute. At least for 4 hours you have started, still the blood pressure is low, then you start using hydrocortisone of 200 milligrams per day in a divided doses. 50 milligrams, you divide into 50 milligrams, 6th hourly you give it 200 milligrams, okay. The steroids will reverses the shock, reduces the requirement of vasopressors and decreases the number of ICU days. So other additional therapies, the purification, blood purification either with selective filters or polymyxin B is not recommended nowadays. There is insufficient evidence. For adults with a septic or septic shock, we recommend using a restrictive transfusion therapy. There are so many trials, use of whether to use 7 or 9 milligram per deciliter of hemoglobin. 7 is preferred, except there are few conditions like patients with myocardial infarction or bleeding patients where you have to maintain little higher. Otherwise, you maintain 7 milligrams, or COPD patient you have to maintain higher. Otherwise, you maintain 7 milligrams per deciliter of hemoglobin. So for adults with a septic shock, recommend using for adults with a sepsis or septic shock, we suggest against using intravenous hemoglobin. It's not recommended. For adults with a septic shock who have high risk for a gastrointestinal bleed, we suggest using a proton pump or ulcer prophylaxis. Suppose a patient on mechanical ventilation, patient is a burn patient, patient with a coagulopathy, or patient is having a liver disease, or a traumatic brain injury, or patients with burns. So you should give a PPEs or a gastric ulcer prophylaxis. So coming to a venous thromboembolism prophylaxis is mandatory. They recommended against using a DVT pumps rather than use a pharmacological treatment, especially use a low molecular weight heparin as compared to unfractionized. It's easy to give, single dose, use a low molecular weight heparin, don't use unfractionized heparin. Then DVT pumps are not, mechanical devices are not recommended as compared to the pharmacological therapies. Coming to RRTs, in adults with a sepsis or septic shock, AKI, we suggest either continuous or intermittent. There is no priority whether you have to use a continuous or a intermittent. So you can use both of them. But in adults with a sepsis or septic shock and AKI, if there is no definitive indication, does not have hyperkalemia, no volume overload, no uremia, or certain pericardial effusion, don't use regularly don't use a RRT. Only if there is a specific indication, then only you start using RRT. Glycemic control, if there is a blood sugar more than or equal to 180 milligram per deciliter, you have to start insulin. That is standard recommendation. Vitamin C, it was a Merrick trial. Last time you have seen that everybody we started using thiamine, vitamin C and a cortisone. So it's against using there is no benefit, mortality benefit, no use of vitamin C routinely in a septic shock patient. So there is no mortality benefit or decreased requirement of vasopressors. So coming to bicarbonate, so for regularly, usually septic shock is a lactic acidosis, the increased amount of lactate is produced. Don't use regularly bicarbonate. When you can use the bicarbonate, the weak recommendation and the low level of evidence is a patient is having acute kidney injury, then it belongs to AKIN classification 2 and 3, you start using bicarbonate. So it decreases the requirement of RRT. Otherwise, don't use a bicarbonate in a patient with septic shock, lactic acidosis. Don't use bicarbonate. Coming to nutrition, early start of a nutrition is recommended within 72 hours. If there is no contraindication, if you have even started low dose of vasopressors are present, use parenteral nutrition you should be started within 72 hours. It prevents the translocation of bacteria. It increases the immunomodulation and increases the sensitivity for insulin. These are 3 advantages for early starting nutrition, enteral nutrition. So there are few long-term recommendations have come recently. I will only tell about a best practice guidelines for long-term care. These are for adults with a sepsis or septic shock. Recommend discussing goals of care and prognosis with patient and families, or no such discussion. So you have to discuss what is the long-term goals. You have to discuss with the patient and patient relatives. For adults with a sepsis and septic shock, we recommend that the participation of palliative care. So you should include a consultation with the palliative care team. Then you refer the patient and family members to a palliative. For adults with a sepsis or septic shock and their family, we recommend a screening for economic and social support. This has been come on the long-term care. For adults with sepsis or septic shock, the families, we recommend the clinical team provide the opportunity to participate in a shared decision-making post-ICU care. So shared decision making has been included. For adults with the sepsis and septic shock, we recommend recounseling medications at both ICU as well as hospital discharge. You have to recounseling regarding what medication has to be taken after discharge. You have to give a proper advice regarding that. For adult survivors of sepsis and septic shock, their families, we recommend including information about ICU stay, sepsis and related diagnosis, treatments and common implements after sepsis in a written has to be sent to the patient relatives as well as patient. For adults with a sepsis septic shock who developed a new impairment, we recommend hospital discharge plan include a follow-up with the clinicians able to support and manage a new condition which has been developed in a hospital. So these are some best practice guidelines for a long-term care. This is a new guidelines included in 2021 surveillance sepsis. To conclude, the recommendation for these guidelines cannot replace clinicians' decision-making capabilities. When presented with a unique patient clinical variables, these guidelines are intended to reflect a best clinical practice. So wherever the strong recommendation, follow it. Wherever the weak recommendation, you have to put your clinical acumen into the practice. Thank you. Thank you for giving the opportunity. Thank you.